When I was asked to talk here, we haven't done that much in inflammation, but we've done a fair amount in pediatric complex regional pain syndrome. And my own interest in imaging had to do with either my pathetic ability to understand patients with pain or just the general notion that, in fact, it's very hard to know what patients tell us. And I've seen about 14,000 patients in my life, and I've suffered from CRPS. And I must say, even when I had it, it was very hard to explain it. I tried to explain it to myself in a way that I thought others may understand. And so what I hope to do today is to tell you what our focus has been, and that is to develop, is there a pointer or not? To develop methods that define objective status, if you will, of disease state for chronic pain and for drug effects. And I think one of the issues that's going on in the field is that we're spending a lot of time trying to understand the disease state. And those in the field, including Karen Davis, who you'll hear from next, and others both in this country, Europe, and in the Far East, have done, I think, a great thing for the field. And that is shown us that the brain is an important part of the pain experience. And really, that is relatively new in the field in terms of being able to show that the brain is doing. And so what I'm hoping to do today is focus on 4 domains. And these are shown in this figure, which we tried to summarize that, in fact, fMRI of the brain can be pivotal to a number of major domains listed here. And I'm going to talk about defining a circuit. I'm going to talk about how we can image drugs in a way that allows us to image drugs that are not petable. And I'm going to talk about altered circuits in pediatric CRPS patients. And if there's time and I'm not thrown out, to talk about the use of animal imaging as a true translational method, a language of translation across species. So with respect to neurobiology, I think this is going to catch a light soon. This paper seems to be burning here. The first is about neurobiology of circuits. And I think we've learned a lot about imaging. And our group has previously published in great detail activation within the trigeminal system from the peripheral ganglia with segmental differences into the brainstem and so forth. And while we're not going to talk about it here, even direct pathways between the trigeminal system and the cerebellum. And so we're excited in terms of using this technology.
Can you speak into the microphone?
How do I speak into the microphone more? This one.
Put it up higher.
Thank you. Is that better?
Yeah.
Okay. So, there are other areas in the brain which we contributed to, including the accumbens, but the question is, how do circuits or specific regions contribute to our further understanding? And so what I'm going to show you is how we've tackled a very small area in the brain known as the habenula. And what we like about the habenula is that it's like Grand Central Station. You can get in there, and you can get out there, and you can go to many parts of the country, north and south and west, not too much on the east. But the point is that the habenula, at least for us, represents an example of how we can tackle specific regions and begin to understand how they dysregulate in chronic disease. And what we like about it is that others in the preclinical domain have actually defined many of the areas that have inputs into the medial and lateral habenula and outputs. And essentially, it's a station that conduits information from the frontal areas to the brainstem areas. And so for a pain neurobiologist or clinician, this is really cool because it talks about the things that we're interested in the pain field. And people such as Bud Craig have shown direct connections from spinal cord through the lateral hypothalamus into the habenula. So it's connected. And this figure is stolen, except for the red, from Dr. Hikosaka from NIH, who is Mr. Habenula Intergalactic. I mean, he's really done the most in this field. And finally, in terms of trying to put this together in healthy subjects, we looked at functional connectivity. And basically what that defines is noted in green above. And it's the ability to understand how different parts of the nervous system are talking to each other at the same time. And we find very high correlation or significance, this is not working, for functional connectivity. Here it is, sorry, it's my inability. Functional connectivity between the putamen and the periaqueductal gray. Now, in the pain field, the basal ganglia have really taken on new interest and importance, and I think we will see in the field that particularly the putamen will play a huge role both in pain and in analgesic processing. And for those of you in the pain field, the periaqueductal gray, which was really put on the map by Alan Basbaum and Howard Fields many years ago, is still considered a sine qua non, if you will, of modulatory outputs of the nervous system. And so the habenula talks to both, as do other areas. And so we are now looking at, and I hope to show you a little later, how the habenula may participate in diseases such as complex regional pain syndrome. So it just shows you how well I can count. This should be section 2, noted as there. But I wanted to give you 2 examples of how we've utilized imaging in CRPS and briefly in migraine because of its potential inflammatory domain in the disease. Our interest in complex regional pain syndrome relates to the fact that essentially, as we see it in our simple way, is it's a group of patients who are otherwise healthy. They may have a predisposition, but they're otherwise healthy, have an incident that turns on abnormal systems that produces multiple dysfunctions in brain behaviors, from pain to, as you heard, movement disorders, autonomic dysfunction, inattention, all these really bizarre processes. And what we've done is looked at 2 groups of patients, groups that have received ketamine, and I'll talk to that in a minute, and pediatric CRPS patients. And what we like about pediatric CRPS patients is not only are they nice to us, but in general, if we do nothing to these patients, and you've heard contrary, but for many of them, if not most, they get better. And so there's something about the immature, developing nervous system that's important about the fact that kids get better and adults don't as easily. And then briefly about migraine and stress and the region that's involved in this disease. So before going to kids, Dr. Schwartzman contacted me about 100 years ago and was interested in looking at the effects of ketamine coma on brain systems. And we were not funded for this study, and we did it in our spare time. And please don't tell NIH that, because you're not allowed to do that. But these patients would come to us before flying out to Germany, where they had this ketamine coma for a week. They're under for a week. And this is one example which we've published. We have 8 or 9 others, which are still in data sets. But here's this young lady in the CRPS positive state, and she drew the affected regions. And just like we heard yesterday, she too had a neck injury or arm injury from a motor vehicle accident. And this was her own drawing again when she came back to see us. So she came in, she had these psychophysic measurements pre and post for peak pain, average pain. And what we did, and more details are in the paper, is looked at, amongst other things, resting states. But before I go there, I must say I'm a religious convert about this process, because here was a woman who was essentially wheelchair-bound, as were the other 8 patients, homebound, and came back bouncing, like one of those rubber balls, bouncing. Walked in, she was back teaching at, I think she taught high school. She now had was getting married, et cetera, et cetera. So from a pathetic, excuse the term, but a pathetic human being to a person who is now back in the saddle. It was, as I said, a religious experience for me, and it tells us something very important about changing brain states. Whether it causes damage to the brain or not, we don't know, but certainly it seems to do something dramatic to these patients. And so we did, unknown to the patients, they had a whole lot of stimuli, etc., but the thing that struck us was when we did resting states, where the patients just lie there. There's no information given to them. They lie in the scanner. We show, amongst other things, changes in essentially the CRPS positive painful state towards the normal healthy state in terms of how these circuits reconvolve, reconnect. And so I think there are ways to objectively define whether you're getting better or not, independent of what patients say. And this is not a trivial thing, and you heard from the last speaker that, in fact, a CRPS patient still has those embers burning in their brains or systems. When they trip up again or have an accident, you're setting off dynamite again. You're not just causing a new entity, you're causing something to happen on an already sensitized brain. And so we were interested in this, and this is a paper that's out in Brain from our group, where essentially we wanted to know what happened to brain processing in a group of kids who had pain, and then we waited for it to go away on visit 2. This was brush-induced, and cold for some reason persisted, and you'll see why it may have persisted. But essentially there was a huge difference on the affected leg in dark gray, and no changes essentially on the unaffected leg in this group. And so we now looked at this in kids who actually undergo physical therapy, and I've always been an advocate for physical therapy, and just like this society is trying to do, physical therapists have not done a good job in terms of defining the utility of exercise, physical treatment, in terms of treating pain disorders. But in this here, we show CRPS versus controls, and this is a resting state difference, showing big differences between the two states. But of note here is our little area called the habenula again that pops up as, for us now, a nice lighthouse signal for potentially differentiating and integrating and understanding frontal cognitive emotional processes and how they can modulate regions in the brainstem. And this is just off the presses, and I apologize, it's actually raw brains, functional scans, not anatomical scans, but you see mapped on these are patients before and after treatment. And the interesting thing for us is that, and maybe shown better in 4 as an example, there is the reappearing, if you will, of resting state frontal activity conditions that may correlate with deficits in cognitive function that these patients have with their pain. I said I'd talk briefly about migraine because we're excited about this as a model to understand not only neuroinflammation but plasticity, and essentially a repeating episodic pain attack in the episodic migraine group, and then a continuous, essentially, pain process in chronic migraine. And we found a number of areas in the brain that are affected that we didn't expect, including basal ganglia, which has just been published, and then again in the hippocampus. And the hippocampus is an interesting area because of its role in stress, and even though people look at it perhaps in a biased manner in terms of memory processing, certainly its role in terms of how it is affected by stress hormones and cytokines is actually well documented in the animal literature. And here we show that in patients who have episodic migraine with low frequency compared with high frequency in gray, there's not only a change shown here where there's an increased activation for the high frequency group in this structure, but also there is gray matter volume decrements. And the way we interpret that relates to what has come out of the group at Northwestern on pruning of dendritic sprouting. So the dendrites have sort of withdrawn, and they're not as complex in terms of their trees, and therefore a volume change. So here I'm back on count. Our group has been interested in defining drug effects, mainly because if you look at almost any drug that's used for chronic pain, maybe even acute pain, no one really knows where they act. And that seems strange because drugs go through pharmaceutical processes, FDA, and all they have to do is suggest a mechanism. They don't have to actually define a mechanism for FDA regulation. And so the question is, can you use imaging to not only enhance drug development in the pharmaceutical sense, but can you use imaging to evaluate drug effects in your patients, whether it's old drugs, currently used, or new drugs. And so here is a study that we've just finished. It's essentially a study that has come out of UCSF, John Levine's group, although we've been helping with the literature. But this is something that they've worked on for years, and that is the issue of how come nalbuphine, an opioid, has different effects in men and women. So if you give nalbuphine to women, it's analgesic. If you give nalbuphine to men, it's anti-analgesic unless you predose with naloxone. And so the question is, how does this change your brain so dramatically? And so taking these two groups, the same group of subjects, but as shown here, they either get naloxone followed by saline, and this is just a 0.4 milligram dose of naloxone. I mean, it's nothing. Or saline, and this should be, so it's either naloxone or saline, or saline and not naloxone. In other words, it's a crossover design. And then they get the nalbuphine infusion. And so what we see in different regions, and this is the bold response in specific regions within the brain of the nalbuphine naloxone activity compared in green versus the nalbuphine saline activity in one region, the caudate. And in other regions, you see opposite effects, and this is shown in the amygdala. And really the summary for us is that you can use PHMRI or pharmacological MRI to take any drug and look at its effects on the brain and even dissect those effects in quite a detailed manner. But when it comes to drugs, and for those of us that are in the clinic, you may resonate with this. Patients come in and they're on pregabalin or gabapentin, and how many of us change those drugs in any kind of organized fashion? In fact, so we have some great clinicians here who do that. But in general, I think patients are left on drugs, and we don't have any readout. But one of the concerns I've had since I actually was one of those who started the use of opioids in patients with non-cancer neuropathic pain is that it just didn't seem to work, and I think the literature is now edging that way. And the question is, how can one evaluate why these drugs may or may not work in the sense that they may be causing significant effects on brain systems? So it's unethical to take healthy subjects, except at Hopkins, right, and give them opioids. So the way we did it is we got a very clean cohort of what we called white-collar opioid addicts. They were all on prescription opioids. They all had no previous pain history or current pain history, they were all psychiatrically clean. However, a small dose of Percocet kicked them off at some point or equivalent, and so they were all on these opioids for over a year. And we see these changes, and this has recently been published in Brain, that in areas such as the amygdala, there are decreased gray matter volume as a result of the drug. And there are also changes in function, which are not shown here, but also in white matter tracts. So what you see here is abnormality in white matter tracts for the opioid group compared with the healthy group. And this is true within each individual. So the uncinate fasciculus comes out of one of the amygdala nuclei, and you can see all the red group here are the opioid-dependent subjects, and their white tracts are much more abnormal than the healthy controls. And so what this kind of data, at least we think, tells us is that if you're on opioids, it's doing things to your brain that may be counter to what the brain may be trying to do on its own in terms of healing or in terms of exacerbating pain, one manifestation of which is perhaps opioid-induced hyperalgesia, which some people think is a big deal. So how much more time do I have?
Pretty close.
Okay, well, I'll just go through a couple of things quickly. Here we have, pHMRI of the NK1 antagonist, which in the pharmaceutical domain was a big deal. It was meant to be the drug to cure pain. And here we have a PET image of the same drug, and this drug's now available for chemotherapy-induced vomiting and nausea. So not only do we get a pattern for pHMRI that is similar to PET, but we also get very specific activation here, as shown in the area of postremia, which is part of that nausea and vomiting center in the brain. So one can use this technology not only to define efficacy, but not shown here is also potential side effects. And then quickly in the last couple of minutes, we have spent years now setting up awake animal imaging. They trained for over a week before this. And what I wanted to show you is our data that we think suggests you can use animal circuits to interpret drug effects and pain effects in a way that essentially this is a language of translation. So here's noxious heat activating similar receptors, both mammalian receptors, but producing activation that correlates for region, that correlates for sign. In other words, there's a decreased signal versus increased signals in the cingulate, decreased in the amygdala, also decreased in human and animals in the accumbens. We can also show changes in disease states. So human subjects who have a migraine or are imaged during a migraine and are given a noxious stimulus have activation in the pulvinar, which we think is part of the central sensitization and a manifestation of generalized allodynia, which together with Rami Burstein, who had been doing this in animal models and as well as clinically, showed that, in fact, if you put an inflammatory soup on the dura and then brush or heat areas of the body, you would actually produce the same generalized allodynia. And here in imaging of rats, in the same model used here, we see the same area in the posterior thalamus that is activated as a result of the migraine state and facial stimulation, which is then inhibited completely by a triptan. So we think we have a nice model to be able to evaluate pain in animals that you can't do things in humans. And so, for example, we're using optogenetics to drive certain regions where you can put viruses in to act as switches for these specific regions. I will skip this, but it's a resting state in awake rats that one can begin to look at disease and drug effects. So I'll end with this slide, and I chose it on purpose because I think the pain field, while clinically we have a long way to go, I think the basic sciences, particularly genetics, I think imaging to some degree, I think the focus on new drugs, as you heard last night, is really in a completely different domain to where it's ever been before. And I think that this kind of meeting and the passion that seems to be flowing forth, that someone is really just over that hill for these patients. So thanks so much.
Any questions? David? So you had I guess, a provocative slide on the effects of opioids and that opioids damage the brain. So one of the issues is you see an effect, a difference between controls and these patients who were on, not patients, subjects who were on opioids. How do you define whether this is an effect of a drug dependency state versus the direct effect of drugs? So unless you take them off the drugs and see a reversal of that, can you really differentiate the two?
Well, that kind of study is very difficult to do. I think what we're saying is that this is the beginning of this inquiry, and that at least on first pass, it's defining something that I think we should be concerned about. I think there is this notion that if you take patients off drugs, then brains can reconstitute to normality. I think the problem we face is if you have pain and drugs, how do you differentiate the two and how they are exacerbated? And so in our simple way, we've tried to do this in various NIH submissions, and it just gets very complicated when you bring the two together without starting at one point. So I think what our next steps are to do things like you suggest. There are also other issues of these patients are very difficult to manage in the sense that once they're off their drugs and treated, and there's an active program at McLean, they generally disappear because they're so happy in general to be clean. So these studies are very difficult, and we've thought about it in a similar way to looking at other effects. But I can tell you, if I were to take you and give you an opioid of your choice, right, and we imaged you before the opiate and afterwards, you would see white matter changes that are a blast. So this is in the published literature for heroin addicts. There's white matter whiteout in terms of anisotropic changes. So I think that there's a lot of evidence from preclinical work in healthy rats and some in monkeys to show that when you give opioids, it does change systems. And whether they are reversible or not, we don't know, but we expect them to be. But the interesting thing, and not shown here, is that not only do we see these morphological changes, but the functional changes are behavioral dependent. In other words, those areas which are related to potential aversive processing, such as not getting your drug and then withdrawal, differentiate from those that are involved in the rewarding stimulus of the drug. So I think, conservatively, obviously I tried to push the envelope, but conservatively we would say this kind of data needs to be repeated. I think it is providing us with insights that we have a real potential problem, that some drugs are not as useful as they may appear to be in the chronic situation. It's certainly true in kids who are put on, antipsychotics, etc. Well, the Ritalins and what have you, that brains are changed. It's not clear if they reverse. So I think we're following that format.